Good afternoon, our dear students. Today we have a new lecture for third-year students who have a first semester or MA groups. And with those groups, we continue studying sub-module, the signs and symptoms of cardiovascular system disorders. Topic of our today's lecture, it is syndrome of coronary insufficiency. This syndrome will be divided on two lectures, today's lecture, and in 2 weeks will be one more. Both of them will be about coronary insufficiency. But if today I'm going to discuss a general information about coronary insufficiency syndrome, or another name, it is ischemic heart syndrome. It is a little bit different, but usually it used by clinicians like synonyms. We discuss in general what is it, and today I'm going to discuss more about chronic forms of coronary insufficiency. And next lecture will contain more information about acute forms of coronary insufficiency, or another name of it, acute coronary syndrome. And plan of our today's lecture is to give definition in general what is coronary insufficiency, to discuss general classification, causes, pathophysiology, risk factors of coronary insufficiency or ischemic heart disease, and more detailizing for chronic forms, it is clinical picture and diagnostics of chronic forms of coronary insufficiency. Let's give definition. Coronary insufficiency, it is a state in which an imbalance occurs between the oxygen supply and demand, which prevents adequate maintenance of metabolic needs of the myocardium, resulting in ischemia of several degrees of intensity. Please pay attention to the first part of this definition. It is the imbalance between oxygen supply and oxygen demand. And we can't name ischemia or coronary insufficiency just the case when it is atherosclerotic plaque obstruct coronary artery, and due to it, it is abnormal blood flow through this artery and abnormal oxygen supply. Yes, of course, it is the most often cause, the most often case, and the prevalence of patients will have this form of coronary insufficiency, but not all of them. In more rare cases, but it's possible, it can be another causes of obstruction of coronary artery and another causes of abnormal oxygen supply, and for example abnormal oxygen demand, like in case of patient, for example, with hypertrophic cardiomyopathy. Yes, when the muscle is hypertrophy, it needs a lot of oxygen, it has a high demand in oxygen, but blood flow is nearly normal, it no significant obstructions, but this normal blood flow is not enough for this demand, and it leads to coronary insufficiency too, and this case can lead to this diagnosis and clinical picture too. That's why it is a very important thing that you should understand that it is imbalance between oxygen supply and oxygen demand. And classification, I already told main classification. We can classify it in general in two big groups, acute forms and chronic forms. In acute forms, we include unstable angina and acute coronary syndrome, which include myocardial infarction. Two main forms we will discuss, it is ST elevation and non-ST elevation. And chronic forms, it can be a lot of forms. The most often of them, it is stable angina. Okay, acute coronary syndromes are named according to appearance on ECG. The main difference between two main types of myocardial infarction. It is presence on ECG, ST elevation. In earlier literature, in more old classifications, you can meet terms like, for example, Q positive or Q negative myocardial infarction. For today, it's not such a specific because presence of pathological Q wave on ECG that is typical for big transmural myocardial infarction is not such informative like, for example, presence of ST elevation. That's why for today, more correct classification, it is ST elevation myocardial infarction or STEMI, and non-ST elevation myocardial infarction and STEMI. Acute coronary syndrome should be distinguished from stable angina, which develops during exertion and resolves at rest. Acute coronary syndrome occurs suddenly, more suddenly than chronic forms. Chronic forms usually gradual. Often it starts at rest or with minimal exertion, or at lesser degrees on exertion than the individual's previous angina. We name it crescendo angina. The onset angina is also considered unstable angina, since it suggests a new problem in coronary anatomy. Chronic coronary insufficiency or stable angina or angina pectoris or just angina, it's all synonyms of the same term. It is a sensation of chest pain, pressure or squeezing, often due to ischemia of the heart muscle from obstruction or spasm of the coronary arteries. The term derives from Latin angere or to strangle. There is a weak relationship between severity of pain and degree of oxygen deprivation in the heart muscle. Usually in some part of patient it presents this relation, but a lot of patient doesn't keep this relation, because it can be very severe pain, but ischemia, it's not MI, for example, it is ischemia, and size of it not a very big, and sometimes it can be big transmural myocardial infarction, very dangerous, very severe, but it is with a very low pain or discomfort, or even it can be silent or non-pain myocardial infarctions. Worsening, or what we name crescendo, angina attacks, sudden onset angina at rest, new onset effort angina, and angina lasting more than 15 minutes are symptoms of unstable angina. It is acute form. Stable, chronic form. Unstable, it is acute form. Unstable angina, it is sudden onset angina at rest and angina lasting more than 15 minutes, usually grouped with similar conditions as the acute coronary syndrome. And we have a Canadian Cardiovascular Society functional classification of angina pectoris. All forms of stable angina, it's connected with stable forms. We can divide it according to functional classes. And to put in your diagnosis severity of angina, we usually in most countries it used this classification. It includes 4 functional classes. Functional class 1 of stable angina. It when the ordinary physical activity, like for example walking, climbing stairs, does not cause angina at all. Angina can occur in such patients with strenuous, rapid or prolonged exertion at work or recreation. What specific activity can lead to angina paroxysm? It is skiing, playing basketball, jogging more than 5 miles per hour, or shovel snow without angina. Functional class 2. It presents slight limitation of ordinary activity. Angina in such patients occurs on walking or climbing stairs rapidly, walking uphill, walking on stairs, climbing after meals, in cold, in wind, or under emotional stress, or only during few hours after awakening. When walking more than 2 blocks on level ground, or when climbing more than one flight of stairs at a normal pace in a normal conditions. What specific activity for what specific activity able such patients? It is ability to garden, rake, roller skate, walk at 4 miles per hour on level ground, have sexual intercourse without stopping. It is abilities for such patients. Functional class 3. In such patients, we see marked limitation of ordinary physical activity. Angina will occur on walking 1 to 2 blocks on level ground or climbing 1 flight of stairs in a normal pace in a normal conditions. Abilities for patients without symptoms with functional class 3. It is ability to shower or dress without stopping, walk 2.5 miles per hour, bowl, make a bed, or play golf, for example. And the last functional class, it is functional class 4. It is inability to perform any physical activity without discomfort or chest pain. In such patients, angina symptoms may be present at rest. Inability to perform activity requiring 2 or fewer metabolic equivalents without angina. Causes of coronary insufficiency. The first one and the most often, which I told you, it is atherosclerotic obstructive coronary insufficiency, or what we named coronary artery disease. It is a main and cause of 90% of all coronary insufficiencies. Other causes can include hypertrophic cardiomyopathy, it's what I told you, increased demand. It can be microvasculature disease like diabetes mellitus and syndrome X. It can be anomalous origin of coronary arteries and coronary fistulas. Pathophysiologically, fundamentally, they include 3 main components that usually in complex give the patient clinic of coronary insufficiency. First one, it is endothelium dysfunction. For today, it is the main pathophysiological mechanism of atherosclerotic plaque formation. You remember in etiology of atherosclerosis, it is a very multifactorial disease, multifactorial disorder, and a lot of etiologies, risk factors can lead to atherosclerosis, but all of them including in one main mechanism, and this mechanism we name endothelium dysfunction. Next mechanism, it connected with atherosclerosis first of all, but can be connected with other causes, other etiologies. It is obstruction of the lumen of vessel. Yes, one more time. It can be obstruction by plaque, it can be obstruction by spasm, or for example obstruction of small vessels with microvasculature obstructions. And third one mechanism, it is thrombosis at the location of lesion. Usually it connected with atherosclerosis too, with the rupture or damaging of unstable atherosclerotic plaque and formation of thrombus on surface of this plaque. And usually it leads to acute forms like unstable angina and especially myocardial infarctions. And a very important thing that I want to add is that the decline of coronary reserve starts when the lesions occupy at least 70% of vessel diameter. What it means? If obstruction less than 70%, it usually asymptomatic. It can be compensated by this blood flow is enough. And when it obstructed on 70% and more, it very narrowed, oxygen supply is abnormal, blood flow is abnormal, and in this case it can lead to clinical picture of coronary insufficiency and angina. And one more time, let's remind the risk factors and different etiologies of atherosclerosis. Hope you know them. From pathophysiology, let's repeat one more time. What is that? It is abnormal lipidogram that include LDL cholesterol, high level small dense of low density lipoproteins, high levels of triglycerides, high level of triglycerides 4 hours after meal, decreased high-density lipoproteins cholesterol, increased levels of homocysteine lipoprotein A, decreased omega-3 fats, presence of diabetes or insulin resistance in patient. It is lifestyle habits like decreased exercise, decreased estrogen levels, especially in women in postmenopause. It is abnormal diet, remote or active infections in patients, increased markers of inflammation, for example, in infections or in systemic inflammatory disorders, increased oxidative stress and decreased antioxidant reserve, activated platelet function and hypercoagulable states. It can be elevated fibrinogen levels that lead to hypercoagulation too. The significant risk factor is visceral obesity, smoking, presence of hypertension, family history genomics, especially in first relatives, parents, children, brothers, sisters. It is presence of chronic stress in patient and different hormonal imbalance. A big number of different endocrinal and metabolic disorders lead to atherosclerosis progression. Clinical picture of atherosclerosis of coronary insufficiency, and especially now we talked about chronic forms. First, it is chest pain or discomfort. It is shortness of breath, it is heart failure, it is irregular heartbeat, nausea, sweating, decreased exercise tolerance, etc. It is the main of them. And schematically on the picture you see that it can be dizziness, it can be pale skin, it can be sweating, arrhythmias, nausea, chest pain that irradiates to shoulder and arm, and can be difficult breathing. Okay, and in discussion of clinical picture of coronary insufficiency, and we told that the main symptom it is chest pain or angina, I want to make a short historical remark to describe you how early and how detailed angina were described earlier. First, who described full clinical picture of angina was a Dr. William Heberden in year 1772. How we described this syndrome? He wrote, but there is a disorder of the breast marked with a strong and peculiar symptoms, considerable for the kind of danger belonging to it, and not extremely rare, which deserves to be mentioned more at length. The seat of it and the sense of strangling and anxiety with which it is attendant may make it not improperly be called angina pectoris. He was the first who used this term. Those who are afflicted with it as used, but while they are walking, more especially if it be uphill or soon after eating, with a painful and most disagreeable sensation in the breast, which seems as if would extinguish life if it were to increase or to continue. But the moment they stand still at this, uneasiness vanishes. In all other respects, the patients are, at the beginning of these disorders, perfectly well, and in particular have no shortness of breath, from which it is totally different. The pain is sometimes situated in the upper part, sometimes in the middle, sometimes in the bottom of the sternum, and often more inclined to the left than in the right side. It likewise very frequently extends from the breast to middle of the left arm. It was a description from William Heberden. You heard how editalized it was. And another more fresh description, it is clinical picture from the nomenclature and criteria of diagnosis and diseases on the heart and blood vessels. In this, it was described in year 1952. One moment, sorry. They wrote, in this syndrome, the major symptom is thoracic pain, which is precipitated usually by effort but sometimes by excitement, a heavy meal, or exposure to cold. The pain is usually substernal or just to the left of the sternum. Occasionally, the pain is epigastric, and in rare instances, it may be localized in the neck or the left arm or shoulder. There is a tendency for the pain to radiate most frequently in the left shoulder and arm, and occasionally to the fingers. Less frequently, it may radiate to the neck, jaw, and teeth, to the back, upper abdomen, or to the right shoulder and arm. At times, the pain will start at one of these points before focusing on the anterior surface on the chest. The intensity varies from a slight sense of heaviness to a severe crushing pain. Yes, it is an actual description for today too. It is a full description of angina paroxysms. Since the precipitating cause is commonly physical exertion, rest usually causes the pain to subside. The length of the episode, therefore, is relatively short. Occasionally, an attack may come on while patient is at rest or even when asleep. The pain is often accompanied by a sense of choking or inability to breathe, which is also relieved by rest. The patients will often complain of flatulence as well. Clinical picture continue. If the attack is not relieved by rest or nitrate and lasts for an hour or more, and especially if it is accompanied by circulatory collapse, myocardial infarction should be strongly suspected. Occasionally, the pain of myocardial infarction may be identical with the pain of the anginal syndrome. The associated symptomatology at subsequent course will determine the diagnosis. And here you see schematically localization and irradiation of chest pain. You see that it usually located substernal in the middle or a little bit to the left, and the most common it radiates to the left shoulder and ulnar aspect of the left arm and hand, and may also radiate to neck, jaw, teeth, back, abdomen, epigastrial region, or right arm. It less typical pain. According to characteristics of this pain, we can differentiate: is it cardiac pain, is it angina paroxysm, or it is another etiology of pain. And for it we use different characteristics that we usually quote in mnemonic dollar, where D is description, O it is onset, L it is location, O it is other signs and symptoms, R relief. And according to this, all of them during examination of patient we detailized. It's not enough for us to ask just if I have chest pain. Patient answer to you, yes, I had. And you have to detailize everything: when start, when stop, why start, why relief, their location, their irradiation, their character, their everything, all information. And according to, you can make screen of this table. According to answers of the patient, you can differentiate and can even suspect some diagnosis if this patient pain is cardiac, and we suspect angina pectoris, stable angina or unstable angina, or even myocardial infarction. Or this pain has another characteristics: duration, type, and other forms of this pain. It can be pleuritic, it can be traumatic, and other etiologies. Second most often symptom in patient with coronary insufficiency, it is shortness of breath. You see it on that picture. Another often symptom it is palpitation and fast heartbeats. It can be accompanied with simple sinus tachycardia or different tachyarrhythmias. Different forms possible for ischemic heart disease or coronary insufficiency. The most severe of them you see here, it is ECG of patient with ventricular fibrillation. Another symptom, another possible clinical symptom, it is nausea. It can be significant sweating, especially typical for patient with myocardial infarction, and even typical for patient with silent form of myocardial infarction, when patient does not feel any pain, but it's some dizziness, some discomfort, weakness, and profuse, very intensive sweating. Very typical clinical picture for myocardial infarction. That's why please be attentive with this symptom. For putting diagnosis, we usually use such test. First of all, it is ECG, the most simple, the most usable, and the most specific test for it. Moreover, we can use stress test. We can implement stress in ECG, in echocardiography, in other methodics I will show you. Echocardiography or heart ultrasound, it includes stress echocardiography, what I told you, and it can be can include intravascular ultrasound. Moreover, the gold standard of diagnosing of coronary insufficiency, it is for today, it is coronary angiography. I will show you it too. Moreover, we can use radioisotopes and other types of visualization, and we use laboratory studies. Here the most important different blood tests. ECG. On ECG, I have on my YouTube channel additional lecture. You can find it previous here on my channel about basics of ECG. And there the main approaches, the main points in recording and interpretation of ECG you can hear there. And on practical class you will discuss with your teacher the most typical signs of coronary insufficiency, chronic forms, acute forms, what ACG changes typical for which forms. If today we discuss a chronic forms, the most often it is ST depression and inversion of changes in T wave. It is the waves on ACG the most responsible for ischemia. And here you see an example of ACG with ischemic anterolateral. It affected anterior leads and lateral leads. Who don't know anything about it, please return to lecture about ACG. And we see in these leads ST segment depression in patient with coronary artery insufficiency. It can be different arrhythmias. The most danger for us it is ventricular arrhythmias, because mostly by ischemia, by coronary insufficiency, it affected ventricle myocardium. What ventricle arrhythmias can be the complications of coronary insufficiency? All of them, many of them you see here on the picture. For comparison, first strip, it is normal sinus rhythm, it is normal ACG. Second picture, it is bundle branch block. It can be right or left bundle branch block. It can be premature ventricle constrictions, or we name it extrasystoles. On third strip, you see it by the arrow. It can be paroxysms of ventricle tachycardia. By the arrow on fourth strip, you see starting of this paroxysm on ACG. Fifth picture, it is long QT syndrome with torsado points. It is a very dangerous and very specific forms of ventricle tachycardia with changes on ACG like sinusoid. You see it on the fifth strip. And last, it is ventricle fibrillation, when it stops normal sinus rhythm and starts such chaotic dribbling of isoli. Here we see another strip. It is a ECG of real patient with polymorphic ventricular tachycardia in torsado points. You see like sinusoid, and it is a picture of patient with coronary insufficiency, and especially this patient, it was patient with acute myocardial infarction. Okay, ECG stress test. If simple ECG, we take patient at rest and record during rest some nearly 3-minute recording of ECG. Usually for some forms, especially chronic forms, it's not enough for diagnosing, because you remember that angina paroxysms usually provoked by physical activity. And to record and put correct diagnosis, we have to give patient some physical activity, some stress to provoke ECG changes, to provoke angina changes, fix it on ECG and put diagnosis stable angina, for example. It look like this. It usually veloergometry or treadmill test like here. Man is running, and during this time, before physical activity, in the time of activity, and just after physical activity, and gradual increasing of it, we record ECG. And for example, usually how we put diagnosis a stable angina without invasive tests. It is receiving ST depression in some level of physical activity on patient's ECG. Echocardiography. Here we see an example of picture with left main stem coronary artery and proximal segment of left anterior descending artery in color-coded transthoracic Doppler echocardiography. And you see by right color that blood flow in this artery in some in some pith not normal, it obstructed. It is a Doppler tool with direct visualization of coronary artery stenosis. You see by lower arrow, it is portion of mid-segment of left anterior descending artery with color mosaic. It is sign of high velocity turbulent flow, that is sign of stenosis too. You see it by upper arrow. Here you see echocardiography with in parasternal short axis view, in a little bit another view. And here it is presence of pericardial infusion. A proximal part of right coronary artery is suspicious for dissection. It showed by arrow dissection. It's like separation of lowers of artery. Imaging plane is of axis of non-dilated right coronary artery ostium. Here it is a little bit another view. It is contrast echocardiography in apical 4-chamber, 2-chamber and 3-chamber views. It is in upper panels. It's demonstrating the extensive reduction of myocardial perfusion in the non-ST elevation myocardial infarction and STEMI patient with angiographic triple vessel decrease, including acute occlusion of right coronary artery and left main stem stenosis. It was confirmed by coronary angiography by invasive test. You see in lower panels. Here you see pictures with a 4-chamber diastolic at the left and systolic at the right. Apical frames at rest in the top panels, peak in the middle panels, and post-exercise in the bottom panels. Images with a patient with previous inferior infarction. Rest regional wall motion was normal, whereas apical hypokinesia developed at peak exercise, like asterix, and had been resolved by the time post-exercise imaging was performed. Here you see another method that is ultrasound too, but it is intravascular ultrasound. It possible when when the hospital have a very thin catheter that is able to go intravascular and visualize the intima, the endothelium or the vessel by ultrasound methodic. And for you a comparison on the left picture, it is a normal coronary artery, and at the right picture it is increased coronary intimal thickness. It is 1.2 millimeters, more than centimeters, suggesting very severe vasculopathy. And what I told, the gold standard of diagnosing, it is coronary angiography. It is an invasive methodic. It is like mini operation when catheter goes through the radial or femoral vein. It goes to the right to the chambers of heart. There is injected contrast. This contrast go to the coronary arteries, and a series of X-ray picture can visualize chambers with a contrast and coronary arteries, full coronary tree, all arteries, and is it present stenosis or spasms or something else there. Here you see such pictures with cardiac catheterization and coronary angiography that shows severe left anterior descending coronary artery stenosis at the left panel with a stent placement in the left anterior descending coronary artery on the right panel. You see example, pay attention to upper vessel on the left. You see that it is significant stenosis, it is abnormal blood flow, and second picture, it is a revascularization. It was open with a stent, and it is nearly normal blood flow through this artery. It is coronary angiography too. You see here a severe blockage in the first picture. It is single vessel coronary artery disease, and the same artery after treatment, after stenting, put stent. It is such metallic device that can open intravascular and open the artery. Here it is angiographies too, with a case of acute myocardial infarction on pictures A, B, and C, and second admissions D, E, and F after treatment and revascularization. On all first pictures you can see stenosis, severe stenosis that lead to myocardial infarction, and on bottom pictures you see coronary arteries after revascularization. Another studies, it is scintigraphy or radioisotopic study. It look like this. Here it can be at rest or stress images, and here you see example of stress images showed by arrows, demonstrate inferolateral and anterolateral of left circumflex ischemia. It can be MRI study. It is not first choice diagnostic for a coronary insufficiency, but in some cases it's usable. Like for example, here we can see a ventricular remodeling post myocardial infarction. You see how changed on bottom picture structure of heart and myocardium. PET or positron emission tomography. It is a very good visualization, non-invasive methodic. It can take function of coronary angiography, but for today it's not available in all hospital. Just a few very big centers available for PET tomography, and it is very expensive. That's why for today the leading position takes coronary angiography. But here you see an example of result of positron emission tomography, and by the arrows it showed infarct zone with entire left ventricle myocardium. CT, not first choice too, but available in some cases. Here, on this example, it shows mild proximal stenosis with expansive remodeling and predominantly non-expansive plaque. You see it by first arrow, and second arrow it is partially calcified advanced mid to distal stenosis. And it can be hybrid imaging. It is cardiac hybrid imaging, integrating single photon emission computer tomography with computer tomography coronary angiography with PET CT with CT angiography is combined. It can be built such a digitalized 3D models. Laboratory studies. They are not a first choice directly for diagnosing coronary insufficiency or atherosclerotic disease or ischemic heart disease, but it is obligatory for all patients, and we usually do it for all patients with coronary insufficiencies. Because it gives us a lot of information about causes, about good ways for treatment of coronary insufficiency and possible complications of these disorders. First, we always do patients with coronary insufficiency lipid profile, because you remember it is a main problem that lead to one of the main problems that lead to atherosclerosis. It is obligatory to check general cholesterol, low density lipoproteins, high density lipoproteins, triglycerides. Moreover, we usually check in lipidogram lipoprotein A. It is an additional lipid test that may be used to identify an elevated level of lipoprotein A, a modification of low-density lipoprotein C that increases risk of atherosclerosis. The test may be used in conjunction with routine lipid profile and provide additional information. Moreover, to all patients, it recommended to do inflammation markers, and the most often of them, and the most usable, it is CRP, or C-reactive protein. It is a marker of inflammation that is associated with atherosclerosis, among other conditions. And obligatory in laboratory studies, it is checking on cardiac enzymes. It is enzymes that are specific for myocardium and can show us necrosis of myocardium and can be the indices of myocardial infarction. The most usable of them include troponins, not just one, several troponins. It is CTMB, or MB fraction of creatine kinase, and myoglobin. It is three the main often detected cardiac enzymes. And by scheme, you see the possible moments, possible schemes of its elevation in myocardial infarction patients. I will tell you more about it on next lecture about acute coronary syndrome. For today, that's all that I want to talk to you. It is all information. As usual, if you have questions, if you have comments, you can leave it here or in our Facebook page. And I ask all students who listen in my lecture to leave your name and group number in the comments under the video. For